Maxillary and mandibular incisors. Anatomy of central and lateral maxillary incisors. Maxillary central incisors include the lingual fossa, wide cingulum. Lingual pit can increase caries risk. If the lingual pit is deep, it can cause developmental disturbance of dens and dont, must be considered. Lingual gingival groove that extends distally onto the cingulum can result in caries. Maxillary laterals include the prominent and centered cingulum, deeper lingual fossa, and rounder crown than the central incisors. Lingual groove that is used to separate the cingulum from the lingual fossa. Lingual gingival groove, lingual pit located in the cingulum on the lingual groove. Lingual groove and distal lingual marginal can be considered clinically adverse factors because plaque can accumulate in the niche-like groove. Roots may curve distally. Mandibular central incisor, smallest teeth of the permanent dentition. Lingual fossa, pronounced root concavities can give double-rooted appearance. Mandibular laterals, slightly larger than the central incisor. The crown appears tilted or twisted distally in comparison with the long axis of the tooth from both the labial and lingual views. Lingual surface has more prominent features as compared to the mandibular central. Mesial marginal ridge and distal marginal ridge are more developed than on a central. Cingulum appears displaced toward the distal. Mesial marginal ridge is longer than the distal marginal ridge, longer root than the centrals. Root impressions on both mesial and distal, but distal are often more distinct. Challenges that present when instrumenting central incisors may be that they are very little with no prominent concavities, except possibly on the lingual of the tooth. For lateral incisors, a challenge that may present is that they can have a plateau gingival groove. For bone loss, adapting to a 1 millimeter, instruments that we can use are the Nevi number 1, good for removing lingual stains, the 5.6 Gracie, the L5.6. For 3 millimeter bone loss, the H6.7 sickle, Nevi number 1, the 5.6 Gracie. For 6 millimeter bone loss, the H6.7 sickle, Nevi number 1, 5.6 Gracie, the younger good, L5.6, and the Sub-Zero for deep maxillary or mandibular anterior pockets. For the lingual, we would also recommend using the beaver tail instrument to assist with staining of the lingual fossa, such as in figure number 52. When scaling, the proximal surfaces are more accessible from the lingual than the facial approach because of the increased tapering of the tooth to the lingual. We must check the mesial and distal root concavities, especially if the CJ is exposed as a result of recession. When a Gracie current does not seem to access as well as you would like, another selection could be the Sub-Zero. It provides excellent access to furcation areas, and it also helps to improve access to deeper pockets in the anterior area. They provide very good adaptation of the blade for narrow root surfaces and tight periodontal pockets. It does have a 50% shorter blade, therefore shorter strokes are needed when instrumenting. For the mandibular anteriors, just make sure to keep the tip 1/3 adapted onto the tooth, making small stroking motions of 1 to 2 millimeters, and keep going up and up until you reach the incisal edge. For the lingual section, just making sure to continue to use 1 to 2 millimeter strokes with the beaver tail portion of the instrument, which will help with removal of staining as well as calculus.
So then when scaling the maxillary of the Langerhans 5.6, I'm going to keep the toe 1/3 adapted. I'm going to start rolling earlier. And then make sure that the terminal shank is parallel with the long axis of the tooth. There should be a little gap right here, that just tells you that the toe 1/3 is adapted to that interproximal area. The mandibular, you can fulcrum on the maxilla extraorally, or you can fulcrum intraorally. So we'll start with maxillary fulcrum. And then to stay adapted with this instrument, you want to start rolling a little bit earlier on the distal line angle to make sure that the toe 1/3 stays adapted. And then you want to make sure that the terminal shank is parallel with the long axis of the tooth. So you can see I start rolling, and then the terminal shank is parallel. Or you could do the intraoral.
So for the anterior incisors, we do use the 6-7 sickle scaler. This has 2 cutting edges on a straight blade which end in a sharp point. To remove the calculus, you want to adapt the lower 1/3 of the cutting edge against the tooth under the deposit. Tilt the facial surface of the blade toward the tooth to achieve an approximate 80 to 90 degree angle between the tooth and the blade. And you want to apply lateral pressure against the tooth and pull the scaler firmly upward to dislodge the deposit.